Pak. Iya. Mantap. Mantap.
Mana Mas Adi? Belum.
Belum. Jadiin gue co-host. Co-host aja. Mana si Faisal?
Nggak tahu. Lima menunggu. Dokter Hasan masuk ya? LZ masukin ya? Oh di mute. Mana Mas Adi? Belum.
Jadiin gue co-host. Co-host aja. Mana si Faisal?
Nggak tahu. Lima menunggu. Dokter Hasan masuk ya? LZ masukin ya? Mana Mas Adi? Belum.
Jadiin gue co-host. Co-host aja. Mana si Faisal?
Nggak tahu.
Dokter Adam belum masuk ya?
Sedang proses tuh.
Ada tuh.
Oh iya. Kosen nanti coba tanya ke anak Surabaya
Iya,
kan?
Iya,
Si Nur lah atau siapalah. Mereka kok bisa bikin SKPID dalam keadaan COVID gini, gimana caranya gitu ya?
baik dok.
Iya, supaya nanti kalau kita selanjutnya ini pakai SKPID aja kita kan?
Baik dok.
Iya. Nah, terus itu saya ada saran kalau memang setuju kalian residen kan, kita lewat IG yang neurovascular itu kan banyak dokter umum itu kan.
Iya dok.
Iya, kan banyak dokter umum. Nanti satu saat nanti kita bikin kalian residen ininya yang senior kita bikin kapan lakukan CT scan, kapan melakukan diagnosa, ya kan? Untuk sharingnya tujuannya ke dokter umum gitu kan, lewat IG itu.
Baik dok.
Dokter Hasan udah masuk?
Sudah dok. Dari Kak Ingrid juga sudah bareng dengan Prof Ikeda, tinggal tunggu masuk dok.
Oh iya. Itu nanti di YouTube tuh banyak banget yang gabung nanti. Kalau bisa pertanyaannya di itu ya. Langsung ditanya oleh Dokter Hasan kali ya. Kan dia host kan? Dia co-host kan?
Ya, siap Bang.
Nanti jangan lupa kami mau gabung juga untuk seminar di Santosa Koko, Pak Dokter.
Bang.
Hah?
Dokter umum.
Dokter umum itu?
Iya Bang.
Saya juga punya sertifikat dokter umum.
No, SKP.
Iya, itu makanya minta tolong tanyain si Nur, tanyain ke Surabaya. Kok mereka bisa?
Tinggal nelpon ID, kita bayar.
Iya.
Bayar.
Bayar.
Iya Bang.
Oh, cobalah tanya itunya.
Ya.
Berapa biayanya kan?
Prosesnya tapi agak ya mungkin lebih dari seminggu lah.
Oh, ya nggak apa-apa kalau kita sudah punya maksud bikin kan,
Iya, Bang.
tinggal diajukan. Nah, gitu loh. Latarnya Hasan bagus yang kayak latarnya tadi si siapa tuh? Tadi siapa host yang pertama itu? Latarnya bagus pakai latar
Oh, back ke flyer.
layar.
Dok.
Hah? Yuris ya?
Pakai akun neurovascular, Dok.
Pakai akun Neurovascular.
Oh. Ya, siapa tahu bisa kirim ke Dokter Hasan gitu kan. Kuisnya udah siap, San.
Oh, good morning. Can you see?
Udah masuk ya. Good morning, Professor.
Yeah. Good morning. Can you see me? No?
Not yet, Ikeda
not yet.
Sensei.
Okay, oh, sorry.
Oke, Sensei, ya.
Just a moment.
Yes.
Itu, camera, yeah. This is not here.
Udah digabung ya.
Sudah, Dok.
Dibantu Inggris kan ya.
Ada Ingrid, Dok, bantu.
Dok,
Bang Grid, gimana? Apa kabar, Grid?
baik dok.
Nah, lebih aman di sana, Ingrid.
Mau pulang,
Iya.
Ingrid.
Lebih aman di sana dia daripada di Indonesia.
Iya dok. Punten.
Kasihan suaminya udah mengharapkan sesuatu dari work from home.
Ya, panen 9 bulan lagi ya, Dok.
Oke dok.
Good morning, Ajay Sensei.
Good morning. Can you see me?
Not yet, Professor.
Not yet. Okay.
Still kanji, writing kanji.
Ingrid, itu mungkin videonya, Ingrid. Join with video, Ingrid.
Itu Zoom. Think
Yeah.
back to Zoom and you have to click this.
Yeah, maybe this one.
Ya.
Okay, Sensei, we see you now.
Okay.
You see?
Yes.
Okay.
Ohayo gozaimasu.
Where are you now, Dr. Adam?
Me.
Yeah, it's just a Japanese.
Oh yeah.
Wallpaper.
It is when I were in Kagoshima, Professor. In Kagoshima.
Kagoshima.
Yeah.
I see.
Good morning.
So, pardon? Yeah, good. Yeah, very.
Hello, how are you?
Yeah, Dr. Ria. Yeah, fine, thank you.
Yeah.
Everyone okay?
Yes.
Yes.
Okay, Professor. There's many alumni from Chukyo in Bandung.
Ini Chukyo alumni in Bandung.
So, can I start now? Wait,
15 minutes.
15 minutes later. Okay. I'm going to present the case and the ruptured ACA aneurysm, and the trapping is done with distal ACA bypass. So,
camera.
One?
Yeah.
Or this one?
Enter the picture of Sensei Ikeda.
Zoom is asking the host is to start the video.
You can try to share screen to us, Sensei Ikeda.
Pardon?
Can you try to share screen from your laptop?
Try to share screen.
Try to share.
This where is it? Yeah. Maybe you can try with that PowerPoint.
Video. I cannot understand this word.
Okay.
What the host is asking me
To be promoted.
to start the video.
Okay. Yes. No.
Yeah, I click this one.
Yeah.
Itu yes aja share video.
Yes, Sensei.
Iya, perfect.
Okay.
This camera.
Yeah.
Can you try to full screen?
Oh yeah, full screen. Okay.
Screen?
Is it full screen?
Okay. Thank you, Sensei. Any video, Sensei?
I'm not sure. Video host is asking me to start your video. Start my video. I'm not sure.
Okay.
Okay. It is working okay.
Okay.
Working well. Okay.
Good access.
So I'll wait for several minutes.
About 10 minutes more.
10 minutes more. Okay. 11 minutes. Okay.
And then you can stop the share screen. Maybe you want to try. Enggak, Dokter Adam.
Oh, nunggu Dokter Benny. Dokter Benny suruh nyoba dulu.
Nanti mungkin dok kalau itu sebagian pertanyaannya kalau memang di live.
IB11 ya.
Ini sebenarnya ada ya.
Nah ini Dokter Benny ini.
Tahunnya dari mana? Dok, ini dok udah online. Halo.
Halo dok. Halo. Dokter Benny selamat pagi. Ini Dokter Ikeda juga udah nyambung dok. Kalau bisa mau menyapa silahkan.
Dikumpul itu juga ada.
Dr. Benny.
Yeah. He's on the camera now.
Camera.
Kenapa kalau video pagi laporannya?
Iya. Ini people.
Firman, tolong di mute dulu Firman. Mute.
Dok, saya dok. Lagi screening dok.
Mute all dulu. Itu yang sama Dokter Benny, tolong dibantu.
Ada berapa pesertanya ya?
Dani sama Dokter Benny enggak ya?
Pepes dok, pepes.
Betul dok.
Iya, pepes ya.
Oh iya. Sudah di mute dok.
Oke. Izin Dokter Benny. Dokter Benny.
Di onin.
Dokter Benny. Pagi dok. Dengan dok.
Ngomong aja dok.
Dokter Benny, izin dok.
Morning.
Enggak, ini tadi nyapa dok.
Izin Dokter Benny.
Kayaknya HP-nya Dokter Benny juga ini ya.
Good morning.
Iya.
HP-nya pepes.
Iya.
Good morning.
Morning, Dr. Benny.
Hello, good morning. Profesor Ikeda. Good morning.
Dok,
Ya.
coba share screen dok. Dok. Dokter Benny, coba tampilin PowerPoint dokter.
Oke. Prof Ikeda. Good morning. How are you? PowerPoint-nya mana? Sama.
Coba full screen dok. Ya dok, oke dok. Dok.
Nanti Dokter Benny bicara yang kedua dok ya setelah.
Ya.
225 ya. Nanti malah jam 9 aja, 10 menit lagi ya, 7 menit lagi ya.
Iya dok.
Terus di YouTube berapa ya?
Halo.
Halo dok.
Terakhir 250 dok.
Udah terdaftar? Maksudnya yang udah join?
Yang
Ya,
sudah
kawan.
join, yang buka pakai YouTube siapa? Firman atau siapa?
Join baru 27 dok.
27 ya.
Udah ada kabar ya? Berapa itu yang di YouTube udah ada kabar berapa jumlahnya? Belum?
Belum dok.
Nggak belum ya? 32 nambah. Tiga enam.
Nah, keren San background-nya.
Ya, Bang. YouTube lumayan.
YouTube ada berapa San?
Ya,
Ada hampir 50-an.
Oh 50-an.
ini banyak banget ini. Ada 200-an kayaknya yang
Oh, yang udah join atau yang belum join, Pak?
yang ini ngantri join kayaknya, Dok.
Yang udah join ya.
Iya, Dok. Tadi saya udah usul ke ini residen, kita bikin juga indikasi CT scan gitu.
Hampir 50-an.
Oh, 50-an.
Banyak banget ini. Ada 200-an kayak. Iya.
Hah? Join atau yang
3 menit lagi ya.
3 menit lagi ya.
Iya. Nanti Hasan dulu yang buka. Biasa
Iya, iya.
Hasan, co-host. Nur, ini kalau orang lain bisa lihat jumlah partisipan nggak, Nur?
Bisa, Dok.
Bisa, Dok.
Bisa. Oh iya.
Dr. Ikeda.
Ya, ya, Dok. Silakan aja, sapa aja, Dok.
Good morning. Bye. Bang, suaranya gitu.
Ingrid, bagus audionya Ingrid di sana? Audionya bagus nggak?
Halo.
Halo Ingrid, monitor.
Halo.
Halo Ingrid, monitor suaranya bagus, audio di sana?
Halo. Gak ada suara.
Hah? Dokter sih bagus, Dok. Dokter ada suaranya bagus.
Suaranya.
Yang lewat Ikeda coba ini. Telepon Ingrid mungkin WA coba.
Gak ada suara.
Morning, Sensei Ikeda.
Ya.
Morning, Sensei Ikeda.
Good morning, Professor Ikeda.
Iya.
Hello,
Ah,
can you hear me?
yes.
Okay.
Kita mulai.
I'm going to start.
Oh.
No pictures, sir.
Okay. Can you see me?
Yes, Sensei.
Mm-hmm.
Okay.
So I'll start now. Okay.
Yeah. Will be open by the host, Professor Ikeda. Wait a minute.
Okay.
Ya.
Udah mulai dan.
Kan buka.
Starting now.
Ayo, San.
Hello, ladies and gentlemen. Good morning from Indonesia. Today we are going to discuss about update on anterior cerebral artery aneurysm. Before we process the webinar today, we would like to express our sincere gratitude to our speaker today. From Neurosurgery Departemen, ACHO Tokyo Hospital, Nagoya, Japan, Professor Akira Ikeda. From Neurosurgery Departemen, Hasan Sadikin, General Hospital Bandung, Dr. Benny Atmadja, Wirjomartani, spesialis bedah saraf konsultan, and Dr. Adam with Moderator from our department. The session will be moderated by Dr. Adam, Specialist Bedah Saraf Consultant, Magister of Science, as a Chief of Neurovascular and Endovascular Committee, Indonesian Neurosurgical Society, Padjadjaran University, Hasan Sadikin. The first speech is about ACA dissection and trapping ACA aneurysm, and ACA side-to-side anastomosis will be delivered by Professor Ikeda. Please, time is yours. Professor Ikeda, time is yours.
Hello everyone. I'm working in Chukyo Hospital in Nagoya City in Japan, and I'm interested in to do bypass surgery for a long time. So this year I experienced a case with the ACA aneurysm, ruptured aneurysm, and we trapped the aneurysm and revascularized the ACA by side-to-side anastomosis. So I'm presenting this case now. So just a moment. Oh, sorry. Can you see? Can you see the PowerPoint? No response. Mute. Can you hear me?
Perfect.
Yes,
Perfect. Yes.
Perfect. And can you see the PowerPoint slide?
Good, Sensei.
Yes, we can.
Good. Yeah. Okay. This is the my PowerPoint, and the case is the old male, 83 years old, and he lost consciousness suddenly with dense right hand paralysis, and the GCS is E1V1M1 on delivery. Then it recovered a little bit, but for a long time he is not dependent. Past medical history included colon cancer, but complete recovery is made. General condition is good, and the CT scan on the day of the onset, massive hematoma is seen, Fisher grade 4 SAH, and the hematoma around the ventricle. And on that day, 3D CTA showed a small, very small aneurysm dilated portion at the distal ACA.
Click this one.
This one?
Yeah.
Okay. Next day, on that day, we did the angiogram, and it showed this is a normal side, no aneurysm on the right side. Sorry, it doesn't work. And on the day, on the left CAG carotid angiogram showed a small dilated area on the distal ACA, but it is so small, so we didn't do nothing on that day. We did blood pressure control or something. But 3 days later, we did this is the CT angiogram again, and the lesion became a little bit bigger. So just a moment. So this would be the region responsible for massive hemorrhage, and on that day we did the we decided to do operation. We thought that the ACA dissection was suspected, but the end vascular treatment was not preferable for there was a massive ICH, so direct clipping and removal of hematoma was considered. Direct clipping is not applicable for dissecting, so trapping would be the best treatment, and with the reconstruction to the distal ACS was appropriate. So bilateral ACA causes position is parallelly, so trapping surgery with A3 side to side bypass was planned. This is just a moment. Can you see the video?
Yes, Sensei. But your picture is not performed in our screen, sir.
Oh, just a moment.
Your pictures.
Can you see?
Yes, yes, we can see.
Yes.
Can you see the? Yeah.
Your video, but your picture is not performed.
Itu dok, kayaknya emang programnya beda dok.
Okay. Please continue, sir.
You can continue.
Okay. We dissect the distal and proximal portion of the aneurysm, but we were dissect when during dissection the aneurysm ruptured, so we trapped temporarily this proximal and distal part. Then we dissected completely the region. This is the ruptured point. We move the clip, and this is the region. This is left ACA, right ACA, and the left and right ACA, cutting the arterial wall. So this is approached through interhemorrhagic fissure. At first, we suture the corner suture. Proximal corner suture. Then we make corner suture at the distal side.
It's left side.
Then using we don't cut the suture, and we use the other side suture continuous suture from the inside of the vessel. Continuous suture is done. This is the completion of the other side suture. Just a moment. Okay, I'm not sure. Then we suture this side. This side interrupted as a STMC bypass. Then remove the clips, and the aneurysm is cut and cut. Then just a moment. So this is the we completed. After that, we removed the hematoma, and this is the postoperative head CT scan, and the hematoma is well removed, and this is clip. Discussion is as shown, and this case had the pathological specimen showed the should aneurysm because there was no wall at some area, so it is not the dissection of the aneurysm, but it seemed should aneurysm, and the but the specimen was small, and it is not clear. So, but the idiopathic should aneurysm of ACA is rare, and there's a treatment option. We did trapping surgery assisted with bypass, and endovascular treatment are not applicable because the should aneurysm, the should aneurysm, it has no wall at all in some area. Then we did the bypass option, and it has some good point, and the maybe using saphenous vein graft or radial artery graft or STA graft, then to ACA bonnet bypass. We do end-to-side anastomosis at that time. It's a little bit big work, great work, and also long. It is a long graft, and the ACA bypass side-to-side anastomosis. In this case, it's easy because we don't need to harvest donor artery, but maybe if it is thrombosed, normal side might be also occluded. So it has those risks together. And the another treatment is transposition of ACA to normal side, region side to normal side. But this has also the risk of thrombosis. And also we can do cut and re-anastomosis of the vessels, but it's too short and tension will be high at that time. So we did that treatment, and we, as a conclusion, is as shown this. Side-to-side anastomosis is not so difficult, but we have to do it in deep position. So we have to train ourselves with a dry model or something. So this is the end of my presentation. Thank you.
Okay, thank you, Professor Ikeda, for your nice presentation. Please.
Thank you.
Yeah, please, if there is question for Professor Ikeda.
Yeah, of course, please.
So, Professor, this is interhemispheric approach, Professor.
Yeah.
Is there how many the incident of the dissecting aneurysm in Japan? How many percent in Japan?
You mean in ACA dissection? ACA dissection is not common. It's rare, but sometimes the VA vertebral artery dissection is sometimes seen. This year we did the dissection of vertebral artery, and in those cases we trapped the vertebral artery, including pica, and we did the bypass, OA pica bypass. And the dissection case is not so common, of course, in Japan.
Professor Ikeda, there's a question from Robert. The question is, can you give us tip and trick in side-to-side bypass anastomosis?
Deep side-to-side anastomosis is what?
Tip and trick.
Tip and tricks.
Tip and tricks. Maybe at first you do usual STMC, maybe 20 or 30 cases, then you will be a good hand. Then try to do train in the deeper field. We use the tissue paper box, empty tissue paper box, and it has a small opening, and we do put small opening, and we put through instrument, and we do in the deeper flow in the deeper area bypass.
Okay, thank you, Professor. There's another question from Edo Siombing. There's two questions.
We do.
How long you operate this kind of bypass?
We do in the deeper area. Not.
Okay, thank you, Professor. There's another question from Edo Siombing. Do you use papaverine or nitroprusid intraoperatively during anastomosis to prevent spasm?
Spasm, this
Yeah.
case.
Yeah, how to prevent spasm?
This case has a SAH is not so severe, so usually we do anticoagulant therapy and also hypervolemia and hypertension therapy.
And how large is the opening for anastomosis?
How long?
How large? How large? How large is the opening for anastomosis side to side?
Would you please speak a little bit more loud?
How large is the opening for side to side anastomosis? The measurement of the arteriotomy.
You mean that time trapping time?
Yeah, no. The arteriotomy.
Arteriotomy is done by using my small knife.
How many centimeter?
Centimeter.
Yeah.
Oh, see. It's in the side to side anastomosis. It's the length of the arteriotomy is twice the diameter of the vessel. 3 times too long and 1 time is too small. So twice the diameter of the length, because it's a best size of the entrance of the floor.
Okay, thank you. There is another question. Are you using heparinization during bypass?
No heparin for the when we do CA and when we occlude the larger vessels, we use the heparin. Sorry. But for the distal vessel bypass, we don't use heparin. Of course we irrigate the inside of the vessel by heparin saline, but we don't use the general medication.
There is another question regarding the mycotic aneurysm. Do you use it in the same position? Do you still the same treatment for mycotic aneurysm in ACA?
You mean a mycotic aneurysm?
Yes.
I'm not sure. It might be the region. Yeah, it might be. I'm not sure.
Oh, yeah. Okay.
But infectious aneurysm is very rare in Japan. I have ever seen some cases, but I'm not sure this case is the mycotic or not.
Okay. How about the timing? When is the best timing for the operation?
Timing of what?
Timing to perform the operation.
Okay. This case has also the aneurysm has every time has the risk of re-rupture. So we do as fast as early as possible.
Because of the rupture.
Of course, we don't start in the midnight, but we start in the morning or noon. But it is better to do early surgery.
Okay. Okay, there's another question from Ferry. How long you put the temporary clip and how long you did the anastomosis?
In this case, Dr. Sakamoto, my colleague, did the operation, and he is the first time to do the ACS bypass surgery, and it took about 43 minutes for establish the bypass flow, and I myself do sometimes 25 or something when due to this bypass surgery.
Okay.
Just a moment. もしもし、後で電話します。Sorry.
Is this is the question from Dr. Asep? It's so there is look like there is hydrocephalus. Did you perform diversion or not in this particular case?
Yeah. We did a shunt, LP shunt later, maybe 2 weeks or 3 weeks later after the onset.
After the operation, there's a question from Dr. Erwin. Do you perform post-op angiogram for this patient? How to
Post-operative angiogram?
Yes.
Yeah, we did. In the aneurysm is of course completely disappeared, and the bypass flow is obtained. And in case of side-to-side anastomosis, we do a continuous suture in the other side, and so this wall is sutured by interruptedly. In those cases, the anastomosis wall, the orifice of the bypass is the continuous suture string would not will be same size, but if the bypass is growing up or blood pressure is high, the continuous suture part, interrupted part becomes bigger, so the opening of the orifice becomes not this side becomes a little bit comes this word upward, and we can see a little bit we can see by angiogram.
There's another question from Dr. Kusdiansa.
I want to ask Professor Ikeda. Is there any sign of vasospasm with this patient? Vasospasm.
Yeah. Spasm is also obtained by angiogram. Yeah. But condition was not good before the onset, and also it was very severe at the onset of that symptom. So he's not in good condition now, and he was sent to rehabilitation hospital after the bypass and the shunt surgery. He was sent to rehabilitation hospital.
Okay, thank you. There's another question. What is the safe of mean arterial pressure during the anastomosis? How about the mean arterial pressure in the enteropathy?
Mean arterial pressure.
Yeah, it is better to keep a higher tension blood pressure during the trapping, during the temporary occlusion of the ACA. So, but when the CA surgery, we do blood pressure should be more than 150. But the bypass surgery, it is not so severe. Not so severe. We do. It should be not lower, but it is okay. Maybe more than 100, I think.
Okay. Okay. Thank you. There's last question. What is the complication for in this particular approach, side-to-side anastomosis in the ACI dissecting? What is the most common complication?
Yeah, it should be, there would be, if the bypass is occluded, the normal side, we use the normal side as a donor side. So if the anastomosis is occluded, the donor side flow is also impaired. So it is the risk, but usually sometimes collateral flow comes well, and I think some case has occluded after the surgery on the normal side also, but there was no trouble at that time. So maybe side-to-side anastomosis is not so risky surgery, I think, but it is difficult to do complete the bypass. You have to do. We have to do train ourselves before the surgery.
There's another question. Is this there's any benefit if we perform ICG during the anastomosis surgery? ICG for anastomosis.
During the surgery?
Yes.
Yeah, we did. Today I used. I made a videogram. Video during the surgery, and then more. This is just a half point. We did ICG after the surgery, and we made a video, but it doesn't work. So using ICG, we can see a good flow from the normal side, and then it goes to the bilaterally. Sorry.
Okay. Okay. Thank you very much for a very nice presentation for us and also for our resident, Professor Ikeda.
You're welcome.
Okay. Okay, next we move to Dr. Benny to have speech for as a second speaker. Dr. Benny, please.
Good morning, Professor Ikeda, Dr. Adam, and all of colleagues from everywhere. This morning, I am presented about vasospasm to rupture anterior cerebral artery, disturbance from learning and behavior. The topic of this morning, I'm talking about anatomy of anterior cerebral artery, the pathophysiology of cerebral aneurysm, affected brain area due to rupture anterior cerebral artery or other aneurysm in other part, pathophysiology of behavior and disturbance due to rupture of anterior cerebral artery. First, the anterior cerebral artery, as you know, is from the carotid branch to medial and anterior. The anterior is before the artery communicant anterior and after. The Professor Takeda cases is on this side. This is maybe the plans of this artery. The rupture small artery or this part. Even the rupture is on this side. There's also, as you see in this slide, there's also blood in the cisterna basalis too. Okay, if you see. This is a branch of the artery cerebral anterior. The arterial risk of the infarction. But in this Professor Ikeda, there's no infarction at all for this, in this case. This is the risk of the infarction of the artery cerebral anterior stroke until this place, until this kind of stroke. Okay. This is the branch of the, you see artery cerebral anterior is on this side. And the bleeding on this side or blocking on this side, there will be a motor and sensory disturbance. Bleeding on this side and the artery is spasm on this side. It's both adjustment disturbance. It depends on which part or bleeding on which part of the arterial aneurysm. The structure supplied by central artery. The central artery is made the artery going to the central part of the brain. The amygdala, uncus, and hippocampal formation is a branch of choroidal artery anterior and temporal branch of posterior cerebral artery. These two blood vessels, most of them supply the amygdala, uncus, and hippocampal. The posterior and posterolateral central artery or anterior choroidal artery is also on this pump. Is also feeding for peduncle, basis pedunculis, substantia nigra, and midbrain tegmentum. Let's go to the medial part. The arteries, anterolateral artery, go to capsula externa and claustrum. The anteromedial, posteromedial, and anterolateral central artery to hypothalamus. This is important if you're blocking or spasm on this area, this hypothalamic disturbance. This anterior and posterior central artery, anterior choroidal artery, on medial artery to internal capsule. That means patient paralysis on the other side. Anterolateral central, anterior choroidal artery also pallidum or globus pallidum. And posterior lateral central artery is pineal gland. This is the supply of the structure of the central artery. I want to talk about much of this, the amygdala hippocampal formation on this other paper. The rupture of the aneurysm caused by the thin of the arterial wall, and after this normal compensation, the rupture, the plate came out all the system on around this blood pressure, and most of them go to the vascular system. The pathophysiology of this lumen and normal wall of the artery. And most of them is the thinness of the lamina, endothelial, and then more thinness, and then so thin, and then the leakage of the vessel, intense remodeling, loss of mechanical process, and blooming. That's the cause of the rupture. The molecular basis of vasospasm after the rupture of the aneurysm is a three kind of the erythrocyte, is hemoglobin, also from heptachrome, and also the apoptosis from the leukocyte. The apoptosis make endothelin, free radical, and cytokine. This kind of material make a vasospasm of the blood, where there is around the blood to a rupture. The superior hematome of subarachnoid hemorrhage pathophysiology effect that the delayed effect is intracranial pressure increasing. Cerebral vasospasm, They are going to talk about more cerebral blood flow reduction, cerebral metabolism rate, oxygen also reduction, autoregulation, impairment. There's no working anymore. CO2 reactive reduction. There's no more reactive if CO2 high is ventilated. There's also impairment. Central conduction time prolonged, and the increasing of lactate in CSF. Also spasm rupture of them. If the ICP increase, the cerebral blood flow decrease. Also, if blood pressure increase and decrease, the ICPP, cerebral blood pressure, also decrease. If blood pressure decreases because of dehydration. Also, dehydration makes viscosity of the blood become increased. Serosity of the blood increase make cerebral blood flow decrease. Decrease of the cerebral flow plus vascular narrowing make infarction permanent. This is a vascular narrowing. We have discussed more about detail of the cerebral vascular. As you see before, that the visible. The spasm is related to the age. You see on this case, most of the spasm on this study is between 50 and 59, 71. In the case of Professor Ikeda, it's more than 80, maybe less spasm than when the patient is between 50 and 59. You see, then, there's no spasm on the case of Professor Ikeda. This mortality rate in the hospital, there's some report from other center. The mortality rate from Lawson stroke, there's no reported. From Basque, and the stroke is 14.2%. There's from hospital Saga is only 7.8% the mortality rate in the hospital. The during patient in the hospital. Actually, the mortality rate is not so high in Japan. In mortality rate of all patients, they are calculated. In Japan, the mortality rate in all patients with subarachnoid only 27%. This is the lowest mortality rate comparing with the United States and Europe. This picture of the midnight, we discussing more from this hippocampus, hippocampus of this region. Why we talking hippocampus? Because hippocampus is a part of the brain that's very sensitive for the hypoxia. This part of the brain for the making decision. To make decision is from three kind of anterior cingulate cortex, orbitofrontal cortex, and ventral medial prefrontal cortex. These three kind, if there is something wrong, you cannot make a good decision. This 3 point from the anatomical is the frontal region destroyed, and anterior cingulate also some deficient decision, it cannot be so accurate. About memory, we know that memory have two kinds of memory, declarative and non-declarative. Declarative memory is a daily episode, word and their meaning and the history. This is most of the functional of the high cortex. Non-declarative motoric is repeating, is motor skill, associated motor and taming and person surfing. These two kinds must be intact. The most patient with spasm that make most of them disturbance in more declarative memory. This kind of declarative memory, which is frontal This including connection between the hippocampus, subcortical, and thalamus. This kind of subcortical, thalamus, and mammillary body. The connection of hippocampus, subcortical, and this can make declarative memory. The projection of hippocampus to cerebral cortex, there's two directions, from lateral view from frontal to hypothalamus, and hippocampus from hippocampus to parietal, from hippocampus to temporal, and to also from hippocampus to cinguli, and also from hippocampus to cinguli. You see the oxygen deprivation. This kind of hippocampus, hippocampus in hypoxic condition, the most disturbance is from CA1 cortex. CA1 cortex is for the recent memory, the loss of the memory and intellectual culture. Pyramidal emerges from this CA1. If hypoxia could happen, the patient will spasm, not only hypoxia but also cerebral problem. This part of the hippocampus more depressed. This is a pathway of the hippocampus to other part of the brain, from dorsal nucleus, vagus, anterior, and also from origin. Also from rapid nucleus, locus ceruleus, also go back to the intra-organ. This can multiple. This from the blue one is leading into, and the out-red intellectual component is the component of limbic system and telencephalon and diencephalon. Between tel and diencephalon, this connection reciprocal. This also hippocampus. Hippocampus after fornix go to the mammillary body to thalamus anterior. This will call it the sequence puppet. This will also make the mammillary body for the memory and judgment. On conclusion, cerebral aneurysm can cause various factors, including genetic and environmental. Rupture of cerebral aneurysm will cause intracranial hemorrhage. Both subarachnoid bleeding, which will be to late vasospasm, especially subarachnoid bleeding in the basal system. Vasospasm often will lead to cerebral infarction. This can potentially cause morbidity and mortality, especially in the long term of the patient. Depend on the area of vascularization affected. Which kind of artery that the vasospasm cause. Various morbidity such as behavior and learning especially when this all the subarachnoid in the basal system. Yes, after the chart, it's recommended to refer patient with arachnoid subarachnoid into specialist to undergo comprehensive evaluation, including cognitive, behavior, psychosocial assessment, because nearly 30% patients who have been creeping or boiling. For the long run, the patient have some problem with cognitive and behavior and psychology assessment. Thank you for your attention. Yeah.
Thank you, Dr. Benny, for your interesting presentation. Is there any question from the floor? This question, Dr. Benny, when we assess or evaluate the behavior, kapan kita mengakses behavior? Kapan kita menilai fungsi kognitifnya, dok? Suaranya hilang, dok. Hello? Hello, Doc?
After the patient, sorry, after this patient discharge and the follow-up, usually just you can only ask, is there any headache, paralysis, or all? But we never ask about the memory, patient memory, or rate memory, or the behavior. Nearly 30% of some report there's some problem, especially between the younger, or less than 40 patients who have aneurysm with subarachnoid hemorrhage, hand and head not so high, that they have some problem. We cannot adjust with the environment and change the behavior. You must ask about the cognitive of this patient.
Okay.
Any other question?
There's another question. When do we consult to the psychiatric department due to the depression if the patient is young and active person?
Yeah, when we have some problem with cognitive or some behavior change, we can ask the other department to take over. Maybe they can give some tranquilizer or treatment for the education. I have one patient with student after the clipping, after coiling, the patient cannot continue their study. It's because they cannot, like before, their aneurysm rupture. Thank you.
Okay, thank you, Dr. Benny.
Yeah. Any question?
Dr. Benny, there's a question from Ingrid. Do you have any experience using neuroprotective medication for SEH? Do you have any experience using neuroprotection medication?
Neuroprotective usually during the hospitalization. So far, there's many neuroprotective with increasing blood pressure, with the blood pressure low. So far, many treatment, but Nimotope is maybe there any benefit for the vasospasm. Nimotope.
Demin suara. Kalau moodnya ditekan
there is another question. In the cognitive function disorder, is it reversible or irreversible, Dr. Benny? If there is cognitive function disorder.
Usually, the first they can memory forget new information, usually, and then later they change their behavior because cannot adjust the life of the surrounding the patient. How about in Japan? I don't know. Is there any problem for the cognitive after severe subarachnoid hemorrhage?
Okay, Dr.
Ikeda?
Prof. Ikeda still here?
I don't know. Because
Professor
we are, how many patients we have aneurysm for last year, Dr. Adam, maybe you can tell us.
Yeah.
How many patients?
Maybe now 30 or 40 SAH patients in a year. So per month, 2 or 3 cases.
In your experience?
Ruptured aneurysm, but sometimes we do same number of unruptured aneurysm cases, which is found by the MRA or something. Incidentally found aneurysm is sometimes crypt.
Professor Ikeda, there is another question for you from Dr. Hasan. The question is, in case of pseudoaneurysm was in vertebrovascular, what is the option of case of the pseudoaneurysm in the vertebrovascular?
Option for pseudoaneurysm in the
Pseudoaneurysm in the Padjadjaran. Yeah, pseudoaneurysm, maybe dissection aneurysm is also same, and it's a very dangerous operation because it is very easily ruptured during the surgery, and also massive bleeding or rebleeding occurs before the surgery, and it's dissection of the vertebral artery sometimes very dangerous. So, I mean, pseudoaneurysm is also same, but the dissection is more common in the vertebral artery than ACA, I think.
Okay.
What
Okay,
is the option? The treatment.
Treatment more option.
What is the option? I mean,
of course, in case with the if the pica is not involved in vertebral artery, it is of course trapped by intravascular surgery. And if the pica is involved, sometimes pica is also closed with coils or something, but sometimes we do bypass surgery for pica. In cases of pica, sometimes we do OA pica anastomosis, or sometimes we do pica to pica anastomosis in the midline from contralateral side.
Okay,
Yeah.
thank you very much for your for answer. Dr. Benny, there is another question for Dr. Benny. What is the risk factor that can cause cognitive problem?
The cognitive response, there's a problem of the patient who are always bleeding with severe subarachnoid hemorrhage. Not every patient with a spasm and a neurological deficit like a cognitive decreasing of cognitive. In that case, I show it to you. The spasm mentioned that between 40 and 50. Less than that is less vasospasm. The cause of the spasmosis depends. If you can make the spasm with MRI, functional MRI, you can see which part of the brain that there some hypoxia or hypoperfusion at the time. You can predict which one will be happen on this patient. If they clear the MRI functional, that everything is normal, maybe they will not have a cognition disturbance. It's my opinion. I have a question to Professor Ikeda, please. Can you have? Professor Ikeda.
Yeah.
In Japan, so many patients with aneurysm comparing with other countries. In your opinion, which one is most patient who has vasospasm problem in their cognitive function? You may experience there. In Japan, vasospasm, how many patient with vasospasm have a cognition function after few years bleeding.
Independent spasm cases, you mean?
Yes.
We have much trouble with the vasospasm, and sometimes they become paralysis, and after the surgery no problem, but later 1 week later he becomes paralytic due to the vasospasm. And also it's we now use some many kinds of drugs to prevent vasospasm, such as I'm not sure the name of the drug. I have forgotten the name, but recently the number of the spasm is decreasing, but still also it has a much problem for us also.
Because treatment during acute phases, you need a dimethob, dimethop, and other drug. The decreasing of the vasospasm is caused of the aggressive treatment during acute phase of the aneurysm. Early surgery and give some drug, any kind of drug.
Yeah, early surgery. We do early surgery as fast as possible, and during the surgery we do we irrigate the cisterns to remove the blood as much as possible, and after that we do sometimes do ventricular drainage or sometimes cisternal drainage, and remove the blood in CSF for 1 week or 10 days. Then if the hydrocephalus is seen, we do shunting surgery.
Now in Japan, the tendency for coiling and clipping is increasing for coiling.
Yeah.
And if coiling, you cannot drain the subarachnoid blood, isn't it? Just coiling without any.
With coil, they less chance to cause vasospasm because we don't touch the vessels, or we do. The vessels are also within the skull, no air, no dry. So it normal temperature. So it is less chance to cause vasospasm than open surgery. But the sometimes spasm occurs even the endovascular surgery cases.
Now clipping is less than coiling. How many percent now coiling than clipping?
Maybe 10% or something, I think.
10% only for clipping.
I'm not sure, sorry.
Yeah, thank you. Any question? Any question?
Okay. Due to the limitation of time, we as a committee would like to thanks to all speakers, to the Professor Ikeda and also Dr. Benny for nice presentation. and also all the participants for joining this webinar. I hope we can meet again in the near future with another topic. Is there any closing speech from Professor Ikeda?
Yeah. Anytime. Oh, so thank you for that web seminar. I appreciate to hear many questions and thinking. Thank you very much.
Okay, thank you very much. Dr. Benny,
Thank you, Professor Ikeda.
Dr. Benny, there's a closing speech from you.
Yeah,
Closing speech.
Professor Ikeda, he will do someday in the next future came to our department doing live surgery, please. Very difficult case. I hope in the next future.
Yeah.
Thank you, Professor Ikeda. Yeah. Okay.
Okay. Okay. Okay. I defer to Dr. Hasan. Dr. Hasan, please, Dr. Hasan.
Ya, terima kasih Dr. Adam. Profesor Ikeda, thank you very much. Ini terima kasih banyak. Kami mengucapkan terima kasih atas semua partisipasinya, para peserta, pertanyaan. Kami meminta salah atau ada kekurangan ini. Wassalamualaikum warahmatullahi wabarakatuh. Stay safe. Semangat dan sehat selalu.